Doctors with disabilities exist in small but measurable numbers. How did they navigate their journey? What were the challenges? What are the benefits to patients and to their peers? What can we learn from their experiences? My name is Lisa Meeks, and I'm thrilled to bring you the Docs with Disabilities podcast. Join me as I interview docs, nurses, psychologists, OTs, PTs, pharmacists, dentists, and the list goes on. I'll also be interviewing the researchers and policymakers that ensure medicine remains an equal opportunity profession. I am so excited to bring you today's episode. This is a story about what happens when things go well and when creativity and a can-do attitude lead the discussion. I've been working with this team now for over a year, and I'm so incredibly indebted to them for their continued desire to learn and grow and share their knowledge of disability inclusion. Today, it is my absolute privilege to return to the Cleveland Clinic, where my health sciences career began, speaking with a team of OB-GYN, clerkship, residency, and clinical leaders, and Theresa Papich, a fourth-year medical student at Case Western Reserve School of Medicine. Throughout our conversations, we discussed the accommodations employed to create equal access and the lessons learned along the way. Most importantly, we talked to Theresa about how this experience felt for her and what she believes schools can do to improve access for learners with disabilities. Let's start with an introduction from the team.
Hello, my name is Craig Nielsen. I am the Assistant Dean of Clinical Education for the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University and Associate Professor of Medicine in the Department of Internal Medicine. And I am responsible for the overall clinical curriculum for our medical students.
Good morning. My name is Stacie Jhaveri. I am the Assistant Clerkship Director under Dr. Diane Young, and I also am the Assistant Residency Program Director for our Obstetrics and Gynecology Residency at the Cleveland Clinic. And so I have a very unique lens to work with all of the learners, including the medical students in the residencies on the inpatient clinical units.
Good morning. I am Diane Young. I am an OB-GYN specialist at the Cleveland Clinic, and I also serve as the clerkship director for our third-year medical students.
Hi, my name is Theresa Papich. I'm a fourth-year medical student at Case Western Reserve University, and I'm applying into internal medicine this year.
Theresa, I'm going to start with you because you are really the main focus of this interview. You are why we are all here today. Can you tell the audience a little bit more about your disability and your disability experience, and then what concerns, if any, you had about going to medical school?
Yeah, so I have a diagnosis of osteogenesis imperfecta. I have more fragile bones and am of shorter stature. Been a wheelchair user my whole life. I use a power wheelchair when I'm out of the house that has a seat elevator, and so that chair has allowed me to be very independent and do a variety of things, including all of these clinical rotations in medical school, which it's just a very crucial tool for me to be able to do the things I want to do. So that's been great. I had a pretty similar childhood and school experience to my peers, with the occasional broken bone, but otherwise a pretty similar experience to my friends growing up and through college. And then when in college, as everyone else, trying to think about what career I might want to pursue later on, I realized that biology and anatomy were my favorite subjects. Initially, being a physician is never something I'd really considered for myself. for different reasons. I think part of that, just knowing my family at that time was a doctor, like it just seemed like something that other people do. And then on top of that, not really knowing other physicians or any physicians who, use wheelchairs or have disabilities from what I could see. But in exploring different careers, that's what I kept coming back to as the best fit for both my interests and my skills. But I, continued to question if that was really a possibility for me, now more specifically related to having a disability. And I did a lot of research, like a lot of Googling, a lot of articles and that I read through. And I remember coming across Lisa Meek's work, and that was also helpful in seeing, oh, there are schools who are excited about having students with disabilities and that might be something that's possible for me. I sent out an email that went to like this network of physicians with disabilities, just saying like, hey, I'm thinking about medical school. Is that a possibility for me? And I got some responses, and that led to a couple of phone calls. One of those calls was with a physician who had my same diagnosis, and speaking to her was really helpful. And I don't know if this will work out for me, but this is what I feel most drawn towards, and I should just go for it.
How critical was that phone call to you going from an interest in medicine to pursuing medical school?
I think it was pretty critical. Having a role model who resembles you more than other physicians, in my case, makes more of an impact, I think, than people probably realize in terms of seeing like, oh, like someone who looks like me can also be a doctor. And especially when thinking about like disability, like, of course, like there's many different forms of discrimination in medicine, but I think with disability, there are some, there's some physical aspects of the job. And so being able to see, oh, someone who has my same abilities is physically capable of this, and that people saw someone who looks like me as someone who was capable of being a doctor. That was definitely very powerful.
Representation matters. I think whether it's disability or another identity that's not often in that physician role, it matters. And many times I think people don't pursue that path or won't pursue that path if they don't feel like there will be some sort of acceptance. So when you were thinking about Case Western in particular, were you aware that they had graduated a wheelchair user in the past and that they had had some experience with this?
No, I didn't know about that at all. What made me interested in the program was just other aspects of the curriculum, and I remember just being excited about what I saw on their website. And honestly, most schools, it was hard to see anything related to disability, so I just kind of picked the ones I liked and cast a wide net. So that was news to me when I got here.
What were your biggest concerns about applying to medical school or going to medical school?
How I would be perceived or how people would see me. I know what I'm capable of, and after talking to, the physician I mentioned, but also just family, friends, and like I had the sense of like, okay, I probably could do this job. Most of it has nothing to do with heavy lifting or standing even. But I think I was worried, will these admissions people and the people interviewing me, will they feel the same way? I was also just worried that at some point in the process, someone would be like, oh, you can't do this specific thing, then you can't be a medical student or you can't graduate. Being someone who didn't even have a parent in medicine or anything, just not even knowing sort of everything that goes into the job and what would be considered like a reasonable accommodation. So there was just a lot of unknowns.
As you heard from Theresa, there wasn't a lot of information on medical school websites related to students with disabilities, and there were almost no physicians with disabilities to serve as mentors. In her case, she was lucky to connect with a physician who shared her disability, a pivotal moment for her decision to move forward and apply to medical school. Also, as a student who didn't have parents or family members in medicine, being a doctor held an air of mystery. But what happens on the other side? How are schools responding? What are their concerns about training a student with a disability? Let's hear from the clinical leadership team about their expectations and the realities of training with Theresa.
Dr. Nielsen, I'm going to switch to you, if that's okay. As an administrator and a leader in the school, kind of in the clinical education space, you play a pretty big role. You set the expectations, I would imagine, around what is possible. In this case, what were your biggest concerns? And were those ultimately true, or were some of those unfounded?
I remember, thinking back to when I met Theresa. So Theresa had an opportunity at our school. Our third year students can go to many different hospital systems. And Theresa chose to come to the Cleveland Clinic for her third year rotations. And I remember meeting with all the clerkship directors at our monthly clinical education committee meeting. And in the beginning, there was a little pushback. Were we the best hospital system for her? Why did she choose us? So I think I was concerned at the beginning about some pushback from not only the clerkship directors, but all the faculty, that there may need to be some accommodations for Theresa to get the best experience. But that really turned out not to be the case. I think it was just a little fear of the unknown to start with, and then that quickly faded once the team met Theresa and we had good plans in place. I also, I think, had some preconceived notions about patient safety. Were there going to be things that could affect the safety of our patients? At the same time, I wanted to make sure that Theresa had a good experience. So I was concerned that these two things may play against each other, but Theresa had a good experience, and the patients benefited from having her on service. I think I did not realize going in the difference in each clinical discipline and the importance of making sure that we looked at each clinical discipline, whether OB-GYN or pediatrics or surgery, a little bit differently, and made sure that we had appropriate plans for each in place. So that took us a little bit to make sure that we approached those all in a similar way to make sure they were successful.
And thank you for your honesty about having the concern that you would get pushback, because everyone does, but people don't really want to talk about it. Everyone wants to paint this flowery picture. But the reality is that the average physician, the average clinical faculty member doesn't know about disability. And what they do know about disability and what they do know about somebody that's a wheelchair user is very much a perspective of, there's a patient that I'm trying to help get better. So they're not coming to the table having a conversation like, oh yeah, this is my colleague and this makes a lot of sense. And fear drives really interesting behaviors. So ultimately, when someone's afraid of something and they don't know how to resolve that conflict, there can be behaviors like avoidance. Well, we just can't do it. We're just not the right place for it. We do leaping to patient safety. That's a pretty common one, to say, well, this wouldn't be safe for our patients. So I appreciate you saying that. And then also kind of saying it really wasn't, at the end of the day, it really wasn't this big challenge that we thought it might be, but that the challenge was more making sure that you understood each individual clerkship and what was needed. I'm wondering, from your perspective as a leader, how your experience with this case and how your experience with Theresa is going to change the way that you would approach disability inclusion cases in the future. How do you think this changed you?
Well, I think it was a wonderful experience working with Theresa. Personally, I think being cognizant of my preconceived notions and my assumptions, and realizing that I shouldn't really assume what the student can do or not do. I should really talk to the student. And so making sure that that's top of mind always, I think, is something I would bring into the future. The other thing is just actual in the trenches involvement. So Theresa started in the outpatient area where I do clinics. So I'm an internal medicine primary care physician. And so I wanted to make sure that Theresa, that we work together really at the start, just to make sure I understood any potential challenges that may arise, and that also just to get Theresa's feedback about how things are going, just to make sure that she felt she could check in and let me know throughout the year if there were challenges. So I think involvement as a leader early on was something that I think would be important in the future as well.
Thank you so much. Leaders do set the tone and they set the culture. So in many ways, your commitment to Theresa and making sure that things went smoothly and that she had you as a contact sent a message to everyone else that this is the expectation that we have here. And that's really important. So, Dr. Young, when I was writing this, I was just thinking about you and just giggling. I was like, I don't even know how to describe, you were really such a force of nature in our communication. And I don't think I've met someone who was so committed to creating the best experience for the student. You went above and beyond to educate yourself, to bring others together. I remember your first email and our first conversation, and I knew that you were dedicated to making this a positive and inclusive experience for Theresa. But what I want our audience to know is not what you did, but why you did it. What is it in your past or your history that drove you to want to create ultimately this inclusive spirit in your clerkship?
We all know that there are biases in medicines. There's unequal treatment, problems with equity. We have an issue in medicine where we're not always inclusive of all parties involved. I was on a mission to make sure that Theresa was going to have a positive experience in the OB-GYN clerkship. Now, granted, OB-GYN clerkship has high acuity, rapid decision making. We are running nonstop, and we have learners that need to learn our field. When I learned about Theresa, it was an opportunity for greatness. However, it's the unknown. I do recall that medical student from Case West Reserve, a wheelchair user student who graduated from Case. I met that student once, not on our OB-GYN clerkship, but in a passing. We also had a radiology resident and an anesthesia resident wheelchair user that I've had experience working with. So I've seen this and I know that it was possible, but the unknown is a little unnerving. The first thing I'm going to do, I'm going to go to the literature. I'm going to look for evidence. I went to the library, spent hours looking at articles on disability. I found a great article in the space of general surgery produced by a group in Colorado where the author was Lisa Meeks. I found several other articles dealing with disability in undergraduate medical education, and that author was Lisa Meeks. So I got the courage to email Lisa to say, Dr. Meeks, can you help us? We have a medical student who's going to be joining us on the OB-GYN clerkship. And, we're doing vaginal deliveries, we're doing hysterectomies, we're doing surgeries, we're doing cesareans. So we got to make sure that it's going to be a safe environment for our patients and for the learner. Dr. Meeks, you emailed me right back. We met several times. I joined a listserv at the national level, including other program directors and other clerkship directors who were also interested in disabilities and undergraduate medical education. And we were on a roll. We met every month. We talked about previous experiences. Lisa, you were invited to one of our meetings, and that was the highlight. You really opened our eyes. We felt that this is something that is doable, but you only get one chance to do it right. So we got all the stakeholders involved. We had several meetings. The best part was meeting with Theresa and learning her story and about her disability and her goals. That was the ammunition that we needed. We were on a roll because she is such a dynamic student and really helped us become successful. The goal was to meet with people often, get all the stakeholders involved. For us, this was an opportunity for greatness because as a physician of color, I've experienced discrimination, racism, bias in medicine, and I wanted this opportunity to show that we can do this in our realm of OB-GYN clerkship.
Thank you so much. You really did dive into the deep end. And what I appreciate about that, and I'm going to bring it back to what Dr. Nielsen was saying, it's what you don't know and that fear that's associated with that that can drive behaviors that lead to exclusion. And so instead of saying, I don't know this is something I'm not comfortable in. And if we don't know, a lot of times we'll avoid it. But instead, you leaned into the unknown, you leaned into what could be fearful. And you said, I'm going to educate myself. I'm not going to assume. And I really just want to thank you for that. I appreciate that. And I think it led to some really good things and will continue to lead to some really good things. Dr. Jhaveri, you have a really unique role in that, and to be honest, I don't think I've seen this role before. I'm sure it exists and I just haven't been paying close attention, but you straddle UME and GME. In being able to be on both sides of the fence, this experience had to be really interesting because you can take what you've learned, apply it in UME, but you can also be thinking downstream to residency. How would this impact our residents? What would this change about the way that I interact with residents with disabilities? Could a resident with a disability become an OB-GYN? Could they go into that postgraduate training and thrive? And they do. We have lots of residents with disabilities in OB-GYN, although it is one of the tougher spaces. We also have lots of residents with disabilities in surgery. I know you've taken a pretty big interest, which I appreciate, in disability inclusion after this experience. How has this experience changed your perception of individuals with disabilities entering medicine?
Oh, I love that question. And I think it's the point and the value of a podcast like this and all of the literature that you've written and we've read, because we focus a lot all the time on creating an inclusive environment and inclusion requiring, including so many different facets, whether it's race or gender or sexuality or disabilities or whatever it is. We use the word inclusion a lot. And I guess this just really provided a real life opportunity to recognize what we don't know, what we are afraid of, where our biases come from. Ableism, a term that I hadn't ever used in a sentence before. And then I found myself feeling those same misperceptions. So the education that's come from it for me has really allowed me to help share that with the residents, with the faculty, with the nurses, with everyone. So whether it's UME or GME or just life in general, I think we all need to continue to just work on how to be inclusive and how to genuinely have a mindset that is authentically inclusive. And I am just forever grateful for having this experience. It was never presented to me in a challenging way. Dr. Young brought it to me with, we have an opportunity. We have an opportunity for greatness. And, her lead and her positivity is the way to set that standard on how this was an inclusive approach, not, hey, we have a problem. What are we going to do? So it's been wonderful for me.
Yeah, definitely. And how will you translate what you've learned in the UME setting to the GME setting? And what ways do you think you can use your experience to improve the residency program?
Oh, I love that. And I don't know that I've thought about that too much. As clerkship directors and deans, we think a lot about the curriculum and student experience and how to best support the learning environment. But on our units, the labor and delivery unit for sure, the residents are first line teachers. So the students work with faculty and nurses, of course, but minute by minute, it's the residents who work with them. So in this situation, our program has grown not by what I would do, but because the residents are first line right there with Theresa, with any student who might have any other disability. And I was just so proud that they really do value an inclusive culture. And watching us grow just collectively, just hearing their ideas. We have 28 residents. Many of them had worked with faculty that had disabilities. So it's not like it's all for us to teach them, and we all learn together. We were able to gather information from everyone on how to not have these biases, not to have that ableism mindset, and to just work together to recognize this is what we need to do for everyone all the time. That culture and that perspective is what has grown based on this experience. And I just want to continue to build upon that.
Yeah, that's amazing. And to translate it to disability in general, right? To not just be focused on somebody with a physical disability or somebody that's a wheelchair user, but to be able to say, okay, there's value in the disability experience that shapes someone into a more empathic provider, can lead to innovation and patient improvement. When we talk about quality improvement, physicians with disabilities, I think, are uniquely primed to be able to do those QI projects because they have been that patient. Oftentimes they will have been a patient in the setting where they work as well. So they know where improvement can occur.
I asked Theresa about what went well. What were the environmental factors that added to a feeling of belonging and inclusion? What made her feel respected? Listen or read along as she discusses the things that meant the most to her.
So I think the advanced planning that occurred before the OB-GYN clerkship and all my clerkships, but was very important. One reason was because just having like a platform from conversations about what my abilities and goals are, but also maybe what limitations I anticipated facing or what obstacles might come up. So I think those meetings created space for those conversations, and then also just allowed us to anticipate. So the planning and those meetings were very important. I think one particular meeting that was very helpful was when I met with Dr. Nielsen and the surgery clerkship director at the simulation center, and that allowed us to start strategizing how I would be in the OR setting, both on surgery and OB-GYN, and helped us kind of work out the logistics of getting me scrubbed in and where I would sit in the OR. So that was very helpful. What sort of would make or break the experience was the attitudes of the residents and the attendings. By and large, everyone was very welcoming and gracious. Individuals made it clear that they were, happy to help me with whatever I needed, that I should feel comfortable asking for help. But beyond that, they would just treat me like they were treating all other med students. Like something that I know my peers and I all really appreciate is when you're invited in to, hey, why don't you help with this? Like, especially with hands-on tasks, office procedures and in deliveries and in the OR, when someone's like, hey, why don't you use these scissors to cut the suture? Or I think just being invited into those hands-on opportunities, and when I was made to feel like they assumed, a level of competence and ability that they would assume about any other medical student, and kind of challenge me to do more and get involved. I really appreciated that, and that helped me have a great experience on all my clerkships. And patients too, like I almost never encountered anything. I just felt like they saw me as another provider that was seeing them. I never, very rarely encountered even a comment about my wheelchair. Yeah, all those things together helped me have a really good experience.
The clerkship director often sets a tone and the expectations. You may be wondering how the Cleveland Clinic Lerner College of Medicine created the accessible environment and made sure that the student had a stellar training experience in the outpatient settings, on the wards, and during the surgical experiences. Let's hear from Dr. Diane Young, the clerkship director for OB-GYN, as she describes the steps taken to facilitate access and inclusion.
I will say, looking at the literature, there's not a lot in OB-GYN, but there is comments on disabilities and other literature. So looking at this literature and looking at other programs that have done this, I realized we can do it, and we can do it even better. It took a lot of behind the scenes work. We will have faculty meetings once a week, and basically we will let the faculty and residents know that our student is coming. We have to make sure we include her. I had an opportunity to work with Theresa in the outpatient setting, and she was just like any other medical student. She was dynamic. She had lots of opportunities for hands-on experience. She rose to the occasion. Patients welcomed her. We did have a very few accommodations that we had to do to make sure she can reach the patient appropriately, but those were pretty easy to do. The labor delivery experience, to me, is quite unique. At the Cleveland Clinic, we're delivering 10,000 babies every year between our two major hospital systems. And it was pretty easy. We work with the residents. Basically, many of the staff will stand when they're doing a vaginal delivery. Well, in Theresa's case, the resident sat on a stool. We had the patient at the level of the resident and Theresa, and they successfully delivered a vaginal delivery, and they successfully delivered the placenta. So I realized with getting buy-in from faculty and residents, it takes very few accommodations to allow Theresa to have a positive experience on a very busy OB-GYN clerkship.
Do you have a minimum number of deliveries that a medical student has to complete in order to reach competency in your clerkship?
So we do have a list of clinical core conditions that students must meet. However, really, they only need to do one delivery, even at the national level. I will tell you at the Cleveland Clinic, students will average between 5 and 11 deliveries when they're on service with us. But the answer to your question is really they just need to do one.
Dr. Jhaveri, bring us into the fold with what kind of task and role you played in making sure that Theresa's experience was accessible. How did you operationalize her accommodations?
Dr. Young mentioned it. We met with the residents as a group because we knew they would be kind of the hands on the ground, boots on the ground team that's going to work one-on-one with her. So we did meet with them multiple times, several months in advance. But students are starting soon. Any ideas? What are your thoughts? What are your concerns? What are your fears? To try to identify their misperceptions. I loved how you commented that when people have fears, they have different behaviors that they end up projecting. And so we identified as many as we could, but we were really happy to find out with the group meeting with the residents that they were just very welcoming. Like, we don't really know why we're talking about this. They really are pretty open-minded, and I hope Theresa felt that way. But really all we gained from that was, well, some pride. I was very happy with how they approached it, but also ideas. Like I said, we had 28 new minds of people that had different experiences in their lives, and they were able to come up with, hey, most of us stand for deliveries, but two of these doctors sit. It's really easy to just sit at deliveries. Let's make that a standard. And it was just nice to have something so simple, to have them think through those processes. What can we do to make those small accommodations that will not alter the patient care? They won't affect the workflow. So we sat with them, got their ideas, and really just got more excited about the opportunity to show what we can do.
And from both of you, and really from Dr. Nielsen as well, I'm hearing repeatedly, correct me if I'm wrong, that there really weren't a lot of accommodations, that the preparation was really key in making sure that everything was implemented, but that there really are not a lot of accommodations that aren't small little things, like moving the furniture so that the wheelchair can navigate the patient room, little things like that, making sure that people are aware that someone might need some assistance in reaching a diagnostic tool. I mean, very, very small things. I know, Dr. Young, one of the big things was, how do we maintain sterility for someone who's a wheelchair user? And the irony of all ironies of the entire thing was that Chris McCullough was the author on the chapter that we wrote, where we delineated the steps to maintaining sterility. So in a full circle moment, the trainee that was a wheelchair user that graduated from Case Western Reserve and went on to be a surgeon wrote the code, if you will, for your student, Theresa, to utilize those steps and to be able to apply that, which I think is this really beautiful full circle moment for Case Western and the Cleveland Clinic. Dr. Nielsen touched on several things at the beginning of this conversation, and so I'm going to bring us back to one of the things that he touched on, and that was patients and patient safety. Did you ever have a moment at any time where a patient said, I do not want to see this student?
When I worked with Theresa, we had a 100% acceptance rate. All patients accepted her, and it was just amazing watching her perform her skills and relationship with the patients, her communication skills. It was effortless. It was with at ease. There was not one issue. Now, granted, when she's doing the breast exam, she would ask the patient to scoot closer to her at the end of the exam table. No problem. She was able to palpate the breast, palpate the abdomen, thyroid, and she did a fabulous job doing pelvic exams and speculum exams. There was some assistance where I would have to push in the step stool so she can get her wheelchair right up to the patient, but the patients were welcoming. If you meet Theresa, she is dynamic. She is so outgoing. She is like any other clinical provider. It was wonderful watching that relationship between her and every single patient. But the answer to your question is there was not one patient who refused a Theresa in their care. Not only did they not refuse her, they welcomed her.
I don't think we ran into any challenges in internal medicine clinic, and I really did not pick patients for Theresa to see any differently. But I remember day one we had her just go straight in, just like I normally do, and it seemed to work out. But Theresa, these patients that we're seeing in clinic know that they're going to see me as well, and a lot of the patients know me. I wonder in the hospital setting, were there any surprises or pushback?
In the hospital setting as well, have never encountered pushback. I don't know, maybe we're just not giving the public the benefit of the doubt enough. I don't know. Like I think I mean, thinking about me as a patient, I feel like I'd be maybe my hesitation would come from that this random student is seeing me, not that their disability status. And so I imagine, these patients know they're at an academic institution, and they seem very open to both, all students, including anyone with a disability, seeing them, at least in my experience. It's one of the most common questions I get, like, oh, how are patients? And like the patients are great. I don't know. Like I've had really good experiences both inpatient and outpatient. Maybe someone occasionally will be like, oh, that's quite a wheelchair or something, but like especially from patients, those comments don't bother me.
What didn't work, or where do you think that there could be some improvement, Theresa?
There were moments where it seemed like some of the sort of initiation of planning or communication, especially to maybe new teams that I would be working with, seemed to fall to me a little bit more than sometimes I was comfortable with, both with just the stress that all third year medical students are under and the time constraints for us, of just managing our schedules and studying. And I remember my first day on benign GYN surgery, a resident, kindly walked me down to the OR, but that scrub team did not seem familiar with the steps involved with getting me into the OR. And so thankfully they seemed to be an especially just kind and also creative team. I was able to tell them what I remembered, like, oh, I think we used these drapes, and they really rose to the occasion and took time to kind of figure things out with me. It felt like there was a little bit more on me to initiate some of those things. The other area was maybe occasionally a mismatch. Maybe where extra accommodations were added that were not needed. I don't think there's a good system in place for for sharing, like, hey, this is what I can and can't do, especially in thinking about clinical settings when, this is my first time being a medical student. Because both sides are still learning, there are some either awkward conversations or either just kind of oversight or over accommodations in terms of what was needed, whether that was, oh, like, I don't actually have accessible parking for students. Like, how do we find parking? Or just small things that kind of fell through the cracks or were overly accommodated because of some of that
Yeah.
miscommunication.
That's probably the biggest thing that happens on most campuses. You've in creating, and this is why I really encouraged all of you to write up this case study, because in creating this new work for the literature, you have gone through and codified these things to say, if we had to go back, these are some of the things that we would do differently. This helps other teams start at, a level that'll be above where you were able to start. They'll say, okay, we're going to learn from what that Cleveland Clinic team did. Just like Dr. Young, you said, we're going to learn from what the Colorado team did. And with each iteration of sharing, we're building on the knowledge and we're perfecting the mechanisms for inclusion, perfecting the communication flow. So, Dr. Young, what would you do differently?
I will say, when you look at the literature, most reports, your book, a lot of the research you've done indicates that you really need about a 12-month calendar year to be able to gather the resources and work through the accommodations. We probably fell just a tiny bit short of that 1 year mark. So we were kind of meeting often, gathering, discussing, lots of phone calls. We were checking in with the faculty residents. It would have been nice to have just a little bit more time to prepare for Theresa. We're in a unique situation because Cleveland Clinic is a 5-year medical school where there are 32 medical students, and we get to see those medical students quite often. Theresa is with our parent medical school, Case Western Reserve. We don't get to learn about those students often, and we take a portion of the Case Western students to come work with us at the Cleveland Clinic. Case Western Reserve knew about her disability from day one, as opposed
Mm.
to our Cleveland Clinic program. So a little bit more time would have been helpful. Although I feel we rose to the occasion. We are Cleveland Clinic. We are going to find a way to make things work. A little bit more time would have been a little helpful.
Yeah, definitely. And you've done a really nice outline in that paper as well, a map of, 12 months out, I would do this, 11 months out, I would do this. And I think it's going to be really, really helpful. Okay, I'm going to circle back to you, Dr. Nielsen. And what recommendations would you have for other leaders that are hoping to grow the diversity of their programs when it comes to disability inclusion?
One thing, obviously, is getting students into your program with disabilities. I'm not on the admission side of things, but I think being open to that is very important. And educate yourself through things such as this podcast and all the great work that you do, and just know that it is possible. Students are often their best advocates, and so learning to work and listen to students really helps the program be successful. And also being open to the fact that you won't get it right the first time, and that's okay. And you need feedback to get better. So, listening to some of the communication challenges that Theresa brought up, you need those things to improve, and don't think you have all the answers and can get everything right the first time. There's no reason students like Theresa can't succeed in our program, just like all other students can succeed in our program. So really just being open and educating yourself.
I want to say briefly before we go to our last question that really the humility and the grace with which the entire team has navigated this is just amazing. And I do think, you are the Cleveland Clinic. You are our leaders. People don't know this about me. I'm proud to live in Cleveland, even though I'm a Michigan person, and I am a patient of the Cleveland Clinic. You do have this international reputation as being the best. And so if we're saying one of the very best hospitals in the world is appreciating, including, valuing disability inclusion, I think that says a lot. That will also catalyze other schools who would say, oh gosh, well, we couldn't do this, to say, okay, well, wait, if that really big system, if that really big powerhouse in medicine is saying this is important, then it becomes important. And I just really appreciate the way that you've navigated this. I have never felt like any of you were anything other than open to discussion, eager to learn, and excited about this experience. And that says a lot about you as individuals, as clinicians, and as leaders. And I just really, really appreciate everything you've done.
As we conclude the podcast, we ask this team to provide any advice they have for students in the pathway to medicine, especially those who are wheelchair users.
To pre-med students in particular, I would definitely recommend doing the same kind of Googling I did in terms of reading articles and publications to learn more about what disability inclusion looks like in medicine, and then to try to find individuals to speak to who ideally have a similar disability, to learn about what their experience is like in terms of things that have gone well, things that haven't gone well, because I think it was important for me to think about real challenges, whether it was attitudes or even just physical things that I needed to consider. So I would recommend that. Something I wish I had done a little bit more is practice possible interview questions that could relate to disability, because I think because it is kind of a new aspect of admissions, and thinking about what accepting students with disabilities into medical school looks like. And so I think interviewers to be prepared for a range of questions, some that maybe they shouldn't be asking, but just be more comfortable with in those moments. I think that's something I wish I had done a little bit more of. And then in thinking about, students entering medical school, all medical students have this fear of, if I mess up, things might not work out for me. Like, I'm going to get kicked out, or I'm going to fail. I won't make it to residency. And it's my understanding, at least, is once you're in, like, the school wants you to succeed and, like, wants you to become a physician. And that applies to those of us with disabilities as well. So I think to not be afraid to speak up about things that aren't working. You might think nothing can be done, but maybe something can be done. And so I think it's always worth asking those questions. I've definitely encountered, the occasional person who says something maybe a little problematic, or, that does hurt me a little related to disability. But I think realizing that most people, there might just be a little bit of the fear of the unknown that we've talked throughout this conversation, but really that once people are given the opportunity to learn and to meet me, get to know me, I think I've really encountered, by and large, really incredible people who are very accepting and want the best for me. So I think just to not be on the defensive too much, and just try to assume the best in people's intentions.
That's lovely advice. I think that's really good advice, Theresa. I don't think we've had people give that advice too often. And I think it's really important to learn how to navigate those conversations, because it will come up. So having some scripted responses so that you can really reserve your emotional well-being and your cognitive energy is really important. Dr. Young, what advice would you have?
I have advice for two groups. The first group would be clerkship directors at the national level. And my advice would be not to be afraid or intimidated to train and teach a medical student with a disability, including a student with a mobile wheelchair disability, because we have shown that we can provide a great experience for a student on a busy, high acuity, fast paced OB-GYN clerkship. So Don't be afraid, because we did it and it was an amazing experience. It helped us grow as individuals. This is a must. It's something we must do at the national level. My second group would be for the trainees. Now, trainees have various types of disabilities. Some we may know about, some we may not know about. And I will encourage all trainees to be advocates for themselves, to come to the table and teach us about your disability. What can we do? Because in the end, we all want the best for the trainees, and we want you to be able to meet the clinical core conditions that we set in front of you. So my advice is keep working hard, advocate for yourself, do not be afraid.
I love it. Thank you. Dr. Jhaveri?
Those are all wonderful. I would have the advice for the educators. Diversity definitely enhances education, it promotes innovation. The list goes on. And when Dr. Young said, don't be intimidated, I think my approach to that would be, we know we want diversity in all forms. When you're presented with something that is different for you, whatever it may be, don't approach it with fear or concern. I heard a lot of people that might say, they won't be able to do this, they won't be able to do this, and all these biases and assumptions. Approach it open-minded, approach it with the lens of how can we get better. Our job is to create a great learning environment. So it should never be a challenge. It should never be a fear. It should just be like, hey, this is what we do. How can we present a great learning opportunity for this learner, no matter what disabilities they may have? The other advice would be to all students entering medical school to be awesome, like Therese. I think we completely overlook that in our clerkship, it's difficult to succeed. All of the students aren't as outgoing. They might not have the same knowledge base. They might not be as proactive. It's a difficult clerkship, unrelated to any physical disabilities. She was phenomenal. Great students tend to have great experiences. And I think my advice would be to those admissions committee, bring on students who are amazing like Theresa is, because it starts with you.
So lovely. Dr. Nielsen?
I think I would just add one thing to everything that's been said, just from a leader standpoint, making sure that the climate is one where communication is open. You need to make sure that if people do have concerns, you're hearing those concerns. If the student is not having a good experience, to make sure they're comfortable in speaking up, and realize you need to keep an open mind moving forward, because things may need to change. So the ability to have a group that communicates well together, I think, is good advice for no matter what you're doing, but particularly in this situation.
Thank you so much for listening to this episode. I want to thank the OB-GYN clerkship team and the clinical leadership of the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University for your work to create an inclusive environment for trainees with disabilities and your honest, thoughtful reflections. And a special thank you to future Dr. Theresa Papich for sharing your journey and helping us all learn. If you or your institution have created a novel approach to disability inclusion or have a case study that you want to share, please contact our show at docwithpodcast@gmail.com. If you like this episode, share it with a friend and be sure to subscribe to our podcast for the latest stories from the Docs with Disabilities team. This podcast is a production of the Docs with Disabilities Initiative and is supported in part by the University of Michigan Medical School Department of Family Medicine M-Disability Program, the Stanford Medicine Alliance for Disability Inclusion and Equity, and the Ford Foundation. The opinions on this podcast do not necessarily reflect those of the hosts, their respective institutions, or the funders. This podcast is released under Creative Commons Attribution, Non-Commercial, Non-Derivative License. This episode was produced by Tamar Fagan, Lisa Meeks, and Jacob Feeman.